So I would like now to show you how our immediate placement and immediate loading work in a digital workflow. We got at our disposal so many digital tools. We have intraoral scanners, we have the face scan, we have planning software, we have CAD/CAM software. They all provide us a precious help, and they make us working differently for planning an implant, foresee its stability, placing this implant, assess the stability with the infamous Osstedt system, and immediately restoring the missing tooth. And of course, all these tools are intended to use guided surgery. It is for us a centerpiece, a mandatory step. However, we'd like to again to alert about the accuracy of this technique, because we still too often meet colleagues who have rejected guided surgery because they encounter difficulties and disappointments on the first use in terms of ergonomics, sensations, and the final outcomes. The creation of the template is the sum of many steps which can include errors, and the sum of these errors, the sum of these inaccuracies, they can lead to an unexpected result. So what does the scientific literature teach us about guided surgery? Regarding the method, what is calculated between a plan and the obtained result is the discrepancy between the entry points, the deviation between the apex, and the angle of deviation between the planned implant and the implant that has been placed. In the 6th ITI consensus conference in 2008, the proceedings of the 7th conference that just happened last month are not released yet. In the 6th ITI consensus, where there are 20 studies, but only one RCT, which has the highest grade of evidence, with 2,238 implants and 471 patients included, we got 1.2 millimeter deviations at the entry point, 1.4 at the apex, and 3.5 degrees angular deviation. They may look like tiny numbers, but in fact, those are very significant. Another interesting meta-analysis performed by the very same team 4 years earlier in 2014 that compared freehand surgery with full guided surgery. They found a 0.4 millimeter difference at the entry point and apex. It doesn't look big, but another important figure to notice is the mean angular deviations between those, which is 1.5 degree. It seems nothing, but depending on the length of the implants, but also the height of the crown above, the repercussion of this 1.5 degree can be very catastrophic for the final prosthetic outcome and for its position, for the channel screw, whatever. So beware. These figures, however small they may be, depending on the situations, they can be very, very significant. So going back to the RCT that has been used, the authors have compared freehand surgery versus pilot-guided surgery. This is a surgery where only the pilot drill will be guided, versus full guided surgery where all the instruments from pilot drill to driver are guided. And they show us pretty good results regarding the deviations, and where full guided surgery numbers were better than pilot drill guidance, which is also better than freehand surgery. But the most interesting part is that the deviations in terms of angulation for the pilot drill guidance is quite close to freehand surgery. And there is a big difference between pilot and full guidance. So in summary, depending on the bone density and the implant design, we can still have strong deviations even if you proceeded the whole sequence of the drilling and not just the pilot drill. There is therefore a real benefit for using guided surgery in your immediate implant placement strategies. So sure, we can use angulated abutments, of course, and angulated screw channels, but in terms of biomechanical considerations, why not having a nice and easy implant axis with guided surgery, whether static or dynamic?